Hi, everybody, and welcome to our module on inflammation principles. Inflammation is the body's process for eliminating pathogens like bacteria and other infectious agents, and also damaged tissue. For example, if tissue is damaged by trauma or surgery, it will heal through the process of inflammation. So this means that inflammation is very common to many of the things we see in our patients every day, things like infections and trauma and surgery. Now, even though inflammation is a good thing, it's the body's process for defending itself and for healing, it can cause damage to the host as well. For example, in sepsis, there's excessive inflammation, which damages the entire body. Inflammation can be prolonged. Some infections fail to resolve, and this can lead to chronic inflammation, which we'll talk about later. And sometimes inflammation is inappropriate. This is the underlying basis of autoimmune diseases. It's inflammation where you don't want it, directed against the body itself. We characterize inflammation as either acute or chronic. Acute inflammation has a rapid onset, usually in minutes to hours, and it resolves quickly, usually within a few days. If you've ever had a sore throat, that's an example of acute inflammation. Comes on quickly and goes away within a few days. In contrast, chronic inflammation is a special form of inflammation that can last for weeks, months, or years. And in another video, I talk in detail about the differences between acute and chronic inflammation. What I'm going to do in this video is talk about the underlying basis of inflammation, whether it is the acute or chronic form. The things we'll discuss in this video are generally seen in both acute and chronic inflammation. Inflammation has 5 so-called cardinal signs. These are the physical manifestations of inflammation that you can see with any form of inflammation. And these were described hundreds of years ago by the ancient Romans, and they're still true today. So the first cardinal sign is rubor, which means redness, and the second cardinal sign is calor, which means warmth. And both of these features, redness and warmth, are caused by vasodilation and increased blood flow to areas of inflammation. Third cardinal sign is tumor, which means swelling, and this is caused by increased vascular permeability that allows cells and proteins, including complement and other important inflammatory proteins, to be drawn in to sites of inflammation. Fourth cardinal sign is dolor, which is pain. If you've ever had a swollen wrist where you've injured it, or a swollen arm or elbow, you know that it can be painful when your body is inflamed. And then the last cardinal sign is loss of function. This is caused by the other cardinal features. When you have a warm, swollen, painful joint or other part of your body, it's very hard to use that part of your body, and therefore you lose function. There are many clinical disorders that present with the 5 cardinal signs of inflammation, but one that's easy to get your mind around is an acute attack of gout. Gout is a joint disease that typically attacks the big toe, and this is an example of it right here. This person's big toe is red and swollen. If you could touch it, it would be warm. It's very painful to the touch, and because of that pain, it will be difficult for this person to bear weight on his or her foot. So all the 5 cardinal signs of inflammation manifesting in an acute attack of gout. For step 1 of your boards, they're going to want you to understand the underlying mechanisms of those 5 cardinal signs. So let's talk about them now. First, let's talk about vasodilation, which occurs in inflammation, and this is what leads to redness and warmth, rubor and calor, like we talked about before. As you may know, if you've watched the cardiology videos, the main vessels in our body that vasodilate and vasoconstrict are the arterioles, and that's also true here. In the setting of inflammation, there is arteriolar vasodilation, and this increases the blood flow to areas of inflammation. So if you look at this drawing on the screen, the capillaries are in the middle, the venous system is on the right, the arterial system is on the left. These arterioles here will vasodilate, and that will draw blood into the capillary system of an area of inflammation. There are a number of substances that are released by cells in the setting of inflammation that trigger vasodilation, but 2 that you should definitely know about are histamine and prostaglandins. Histamine is a small molecule. This is its structure shown on the screen. It is stored inside of mast cells, basophils, and platelets. And these cells preform this. In other words, they make it outside of the setting of inflammation, and they have it ready to go. So when there's an inflammatory trigger, histamine is released quickly and causes vasodilation. And that is one of the factors that leads to the rubor and calor like seen on this person's foot on the screen. Second important trigger for vasodilation are prostaglandins. These are released in the setting of inflammation by mast cells and leukocytes, and they are actually not preformed. They are synthesized when inflammation occurs, and they are derived from arachidonic acid. This is the structure of prostaglandin E2 shown on the screen here. Note that it's a much bigger molecule than histamine. Note also that it contains lots of carbons and hydrogens, and therefore it is a lipid structure, and it's derived from lipids. Prostaglandins are an example of a signaling molecule called an eicosanoid. Other eicosanoids include leukotrienes and thromboxanes, and all of these substances are derived from arachidonic acid. They're sometimes referred to as arachidonic acid derivatives. The way this works is, in the setting of inflammation, phospholipase A2, an enzyme found inside of cells, pulls lipids from the cell membranes to make arachidonic acid. This is its structure shown on the screen here. Note that it's a large hydrocarbon structure, and that should make sense to you because it comes from lipids. From arachidonic acid, there is an enzyme called lipoxygenase, which can make leukotrienes. There's also an enzyme called cyclooxygenase, which can synthesize thromboxanes and prostaglandins. And prostaglandins are some of the substances that cause vasodilation in the setting of inflammation. Another important substance that triggers vasodilation in the setting of inflammation is bradykinin, and bradykinin is interesting because it is linked to the clotting cascade. In the setting of inflammation, there's an increase in clotting factors, including factor 12, which is the Hageman factor. This is a component of the clotting cascade that I talk about in the hematology section, although it has a very minor role in the clotting system. Its more important role is that it leads to the production of bradykinin. Activated factor 12 can convert a substance called prekallikrein into kallikrein, and then kallikrein can convert a substance called high molecular weight kininogen into bradykinin. These substances are around in the setting of inflammation, and therefore when factor 12 becomes activated, that leads to more production of bradykinin. Bradykinin is a vasodilator and therefore contributes to the vasodilation seen in inflammation. It also increases vascular permeability, which we'll talk about in a minute, and that leads to swelling and inflammation. It's also important as a cause of pain. It triggers pain in our nerve fibers, and an easy way to remember this is that the B in bradykinin is for boo-boo, like when you fall and hurt yourself and get a boo-boo. Two other important things, especially for step 1 related to bradykinin: it is degraded by angiotensin converting enzyme, and therefore patients who take ACE inhibitor drugs for hypertension or heart failure will have an increase in bradykinin levels. And because bradykinin causes vasodilation and an increase in vascular permeability, one of the potential side effects of ACE inhibitors is angioedema. That's basically swelling and vasodilation like you would see in inflammation, but it's not occurring from inflammation. It's occurring because someone took an ACE inhibitor drug. Another thing to know about bradykinin is that it's degraded by the C1 inhibitor of the complement system, which I talk about in the immunology videos. This means if patients are born with a deficiency of the C1 inhibitor, they will always have high levels of bradykinin, and therefore they will get recurrent bouts of angioedema. This is a condition called hereditary angioedema. Basically, what's going on here is because there's too much bradykinin around, these patients are developing signs of inflammation like redness and swelling outside of an inflammatory trigger. Now let's talk about the cardinal sign of tumor, which means swelling. This is caused by an increase in vascular permeability that occurs in the setting of inflammation. There are a couple of reasons that vascular permeability increases. First of all, it is sometimes caused by direct injury. If the cause of inflammation is damage to blood vessels, then that will lead to leakage of plasma. There are also many mediators that cause an increase in vascular permeability. These include a couple of leukotrienes. Those are the eicosanoids we talked about earlier. Also histamine, and as I mentioned, bradykinin. All of these substances cause contraction of endothelial cells, which creates gaps between the cells. This occurs in the post-capillary venules, and it's high yield to remember this. If you look at this drawing on the screen here, these are the capillaries, these are the post-capillary venules, and that is where vascular permeability is going to increase, and that happens because two endothelial cells, which might be sitting next to each other and touching, will contract and separate. This will create a gap between them, and that will allow leakage of plasma. Another contributor to the swelling seen at sites of inflammation has to do with changes in oncotic pressure, and it's very high yield for you to understand this for your board exams. In the cardiology section, in the video on regulation of blood flow, I talk about capillary fluid movement. By way of review, within the capillaries, there is a hydrostatic pressure P sub C and also an oncotic pressure pi sub C. The oncotic pressure is created by proteins, especially albumin, and the hydrostatic pressure is basically the blood pressure. There is also, within the interstitial space surrounding the capillary, a hydrostatic pressure P sub I and an oncotic pressure pi sub I. And generally, the hydrostatic pressure is higher in the capillary, which tends to drive fluid movement in this direction. And generally, the oncotic pressure is higher in the capillary, and that tends to resist fluid movement out of the capillaries. What happens in the setting of inflammation is, like we talked about in the last slide, there is leakage of plasma, including protein, out of the postcapillary venules and into the interstitial space. This raises the oncotic pressure in the interstitial space, and this draws fluid out of capillaries into the tissue. So even in parts of the vasculature where the endothelial cells have not contracted to allow for leakage of fluid, there will still be more fluid movement out of capillaries, and that's because the oncotic pressure in the interstitial space at sites of inflammation has gone up. And I've summarized these points on the slide. Oncotic pressure changes drive fluid into tissue at sites of inflammation, and this is caused by a rise in the oncotic pressure in the interstitial space caused by protein influx. When you evaluate patients clinically, you will often identify tissue edema or swelling as part of a disease process. For example, that swollen big toe we saw earlier from gout is an example of tissue edema, but there are many other disease processes that also lead to the same thing. There are basically two reasons why tissue edema can occur as part of a disease process. The first reason is called an exudate or an exudative form of edema. This is what we've been talking about up to this point in this video. An exudate means fluid leak into tissues that is in form of inflammatory edema from high vascular permeability. And this is what you see in the setting of infections and malignancy. In all these conditions, there are leaky vessels that allow fluid to leak out into the interstitial space and cause swelling. This fluid that is causing the swelling in these situations is said to be an exudative fluid, and the characteristics of an exudative fluid are a high protein content similar to plasma and a high specific gravity, meaning the fluid is concentrated. The reason it has these characteristics is because the cause of the swelling is leakage of plasma, and therefore the tissue edema is close to having the characteristics of plasma. But there is a second reason that tissue edema can occur, and this has nothing to do with inflammation, but it looks the same. It can be hard to tell the two apart. The second type of tissue edema is called a transudate. This is caused when there's very high hydrostatic pressure or low oncotic pressure inside the capillaries. If we look at our drawing on the screen here, remember that the hydrostatic pressure in the capillary drives fluid out into the interstitial space. So if this hydrostatic pressure is very high, that will lead to leakage of fluid, but this has nothing to do with inflammation and nothing to do with an increase in vascular permeability. The same is true if the oncotic pressure in the capillary falls for any reason. Say, for example, the patient is losing albumin from renal disease. That patient will have a low capillary oncotic pressure, and this will favor movement out into the interstitial space. But once again, this has nothing to do with inflammation. So transudates are fluid leaks not due to inflammation, but in contrast to exudates, these fluids that are found in tissue have a low protein content. That's because albumin remains in the plasma and doesn't leak into the interstitial space with the fluid. They also have a low specific gravity. They're very dilute and not concentrated, and that's because only water is moving in this direction. It's not carrying proteins and other contents with it. So I've explained to you the difference between an exudate and a transudate because that difference is very important in a common clinical dilemma, and that involves determining the cause of a pleural effusion. Shown on the screen is an X-ray from a patient with a pleural effusion. This patient has a fluid collection in the pleural space surrounding the lungs. Sometimes when you see a patient with this, you don't know what has caused the effusion, and there are a couple of potential causes. The effusion could be an exudate, and if it was, that would mean it might be caused by an infection or malignancy. On the other hand, the effusion could be a transudate, and if that's the case, it could be caused by high hydrostatic pressure, like you see in heart failure, or low albumin, like you see in liver and renal disease. How are you going to tell the two apart when they look the same on X-ray? They just appear like a pleural effusion. Well, the way you do this is by doing a test called a thoracentesis, where you insert a needle and take a sample of the pleural fluid. You then test the pleural fluid for the concentration of protein and lactate dehydrogenase, an enzyme found in plasma and pleural fluid. What you do at that point is you compare the concentration of those substances in the pleural fluid to that in the serum, and the ratio of these two numbers will be close to 1 if the pleural fluid is an exudate. That's because in an exudate there is leakage of plasma or serum contents, and therefore the pleural fluid concentration is very close to the serum. On the other hand, if it is a transudate, the plasma concentration will be very low relative to serum, and this ratio will be far away from 1, something like 0.1, 0.2, or 0.3. So what you do is you analyze the pleural fluid, then you apply what's known as Light's criteria. Light's criteria says the effusion is an exudate if the pleural protein to serum protein ratio is greater than 0.5, or the pleural LDH to serum LDH ratio is greater than 0.6, or if the pleural LDH is greater than 2/3 the upper limit of normal for the serum LDH. It's not important to memorize these criteria as a med student preparing for step 1, but you should get the general idea, and that is that the makeup of the pleural fluid is going to be close to serum if the fluid is an exudate. On the other hand, it's going to be relatively dilute compared to serum if the pleural fluid is a transudate. Moving on, let's talk about our next cardinal feature of inflammation, and that is dolor or pain. The most important mediator to remember as regards to pain is prostaglandin E2. This is produced in the setting of inflammation and it increases the skin sensitivity to pain. It also causes fever, which we'll talk about in a minute. And an easy way to remember this is that pain and fever are both in the name of PGE2. Pain is right here and fever is right here. So the five cardinal signs are the local signs. They occur at the site of inflammation. But in addition to things going on at the site of inflammation, there's a systemic response to inflammation. And you know this if you've ever been sick, maybe with a GI infection. Even though the inflammatory process may be in your stomach, you otherwise feel overall sick. Those are the systemic signs of inflammation. We're going to talk about three of these now. The first one is fever, the second one is leukocytosis, and the third one is a rise in substances called acute phase reactants. So let's talk about the mechanism of fever. Fever is caused by substances known as pyrogens. All of these substances are capable of increasing the activity of the enzyme cyclooxygenase in the hypothalamus in the brain. And recall that the hypothalamus is the temperature regulatory center of the brain. If we go back to this slide, cyclooxygenase is the enzyme that can convert arachidonic acid into either thromboxanes or prostaglandins, and its activity is increased by substances that are pyrogens. The increase in enzyme activity leads to a rise in the level of prostaglandins in the hypothalamus, and this is what leads to fever. There are a number of pyrogens that occur in the setting of inflammation. Lipopolysaccharide, which is found in many bacteria, is called an exogenous pyrogen because it comes from outside the body. IL-1 and TNF are cytokines. These are produced in the setting of inflammation, and these are endogenous pyrogens because they come from within the body. And so these pyrogens lead to higher levels of prostaglandins in the hypothalamus, and that's what raises the temperature set point. And of all the prostaglandins, the most important one for you to remember as regards to fever is PGE2. And like I told you before, PGE2 also causes pain, and pain and fever are both in the name PGE2. Another systemic sign of inflammation is a leukocytosis or a rise in white count. This is classically seen in the setting of infection, although you can see it in the setting of inflammation from other causes. So a normal white count is less than 11,000. In the setting of infection, it can rise to be as high as 15 to 20,000. In some cases, when there's a raging infection, it can even get as high as 100,000 or rarely higher. This is referred to as a leukemoid reaction because it resembles leukemia. And a very high yield thing to remember for step one is that Bordetella pertussis, the bacteria that causes whooping cough, is famous for causing these very high white counts. We don't see Bordetella much anymore because of vaccination, but when it does occur, the white count can get very, very high and mimic leukemia. The cause of leukocytosis is cytokines, especially TNF and IL-1. They trigger cells from the bone marrow to produce more white cells. And the type of white cells that rise in the setting of infection vary with the cause of infection. Bacterial infections usually cause a rise in neutrophils. This is called a neutrophilia. And in the setting of viral infections, there's usually a rise in the lymphocyte count. This is called a lymphocytosis. In the setting of bacterial infection, the leukocytosis often demonstrates a feature known as a left shift. This is part of the normal response to infection. It involves the bone marrow producing more bands, which are immature neutrophils, as well as more neutrophils. To understand this, let's look at this table on the screen. So a normal white blood count might include 10,000 white cells, 55% of which are neutrophils and 5% of which are band forms. In the setting of a bacterial infection, not only will the white cell count go up to 17,000, but the percentage of those white cells that are neutrophils and bands will also rise. This is referred to as a left shift. It gets that name for historical reasons, and it's just part of the normal response to a bacterial infection. For the remainder of this video, I'm going to talk about acute phase reactants. These are all serum proteins whose levels rise in the setting of inflammation, either acute or chronic. Most of them are produced by the liver, and their synthesis is increased usually by cytokines. For most of these, the cytokine that drives their synthesis is IL-6. There are 5 acute phase reactants that are important for you to know, and we'll go through all these in the next few slides. C-reactive protein is usually just called CRP. Liver synthesis of this substance increases in response to IL-6 from macrophages. It has some antibacterial properties. It can bind to bacterial polysaccharides. It can also activate the complement system. And the place this usually comes up clinically is that higher levels are associated with coronary artery disease. Coronary artery disease is an example of a chronic inflammatory process, so patients who have this ongoing in their vasculature have higher levels of CRP, so it's sometimes used as a risk factor to identify patients who might have coronary disease. Serum amyloid A proteins are apolipoproteins that have many roles in the inflammatory response. They're important clinically because they cause a form of amyloidosis called AA, or secondary amyloidosis. In the hematology section, I have an entire video on amyloidosis, but for our purposes here, just know that serum amyloid A proteins rise in the setting of inflammation, and therefore in chronic inflammatory conditions, these proteins can deposit and form amyloid, and that's why secondary amyloidosis is seen in the setting of chronic inflammation, like in rheumatoid arthritis, ankylosing spondylitis, or inflammatory bowel disease. Ferritin is a protein that binds iron. It's the iron storage protein. When iron is stored inside of cells, it is stored bound to ferritin. And you can find iron stored like this inside of macrophages of the liver and the bone. And this has clinical significance if you're trying to diagnose iron deficiency. In the anemia videos in the hematology section, I talk about how to diagnose iron deficiency anemia. And one of the ways you do that is by measuring the ferritin level, which will be low in the setting of iron deficiency. However, if you're trying to diagnose iron deficiency and the patient has an infection or has some other type of inflammatory process, it makes the ferritin measurement unreliable. And that's because iron deficiency would usually lower the ferritin, but inflammation raises the ferritin, and therefore interpreting the ferritin in the setting of inflammation is hard to do, and therefore we usually don't try to diagnose iron deficiency using the ferritin level in the setting of inflammation. Hepcidin is another acute phase reactant. It has some antibacterial properties. It's important clinically because it inhibits iron transport. It binds to something known as ferroporitin in cells of the liver as well as macrophages. This leads to iron being trapped inside of cells as ferritin, and this contributes to the anemia of chronic disease, which I talk about in the hematology section. And our last acute phase reactant is fibrinogen. This is factor 1 of the clotting cascade. It promotes adhesions between cells, especially platelets and endothelial cells. And this is helpful in the setting of inflammation, and that's why its level rises in inflammation and why it's an acute phase reactant. Sometimes we see patients clinically who have pain and maybe fever, and we wonder if an underlying inflammatory process is the cause of their disorder. Well, the way you can work this up is by measuring what's known as the ESR, or the erythrocyte sedimentation rate. This is the rate at which red blood cells fall to the bottom of a test tube. Normally, they fall at a rate of 0 to 22 millimeters per hour for men and 0 to 29 millimeters per hour for women. It's a very simple test to perform. You just put a sample of blood in a tube and you determine the rate at which the red cells fall down to the bottom. The reason this is a helpful test clinically in determining that inflammation is ongoing inside the body is because the ESR is increased by acute phase reactants. So we rarely measure the level of fibrinogen or the level of CRP to diagnose an inflammatory process. Instead, we measure the ESR, and that's basically a screening process for whether or not levels of all acute phase reactants are high within a patient's serum. The reason the ESR goes up in inflammation is because the rate at which the red cells sediment to the bottom of a tube is determined by a balance of factors. There are some factors in the plasma that are pro-sedimentation, so all of the acute phase reactants, but especially fibrinogen, increase the sedimentation rate. That's because they cause red cells to stick together, and therefore they fall faster to the bottom of the tube. There are also factors that are anti-sedimentation, especially the negative charge on red blood cell membranes. This tends to keep red blood cells apart and cause them to fall more slowly. When you have high levels of acute phase reactants, especially fibrinogen, the red cells will stick together, they'll fall to the bottom faster, and this will raise the ESR. And this is why the ESR goes up in the setting of inflammation when acute phase reactants are higher in the plasma. So a normal SED rate is less than 30. A very high SED rate over 100 can be seen in some of the conditions listed on this slide. You can see this in endocarditis, temporal arteritis, polymyalgia rheumatica. You can see this after trauma or surgery or in the setting of some malignancies. And some of these conditions, especially endocarditis or temporal arteritis or polymyalgia, can present with nonspecific symptoms where the diagnosis isn't clear, so identifying a very high SED rate helps to narrow down the differential. Another famous cause of a high SED rate is anemia. The reason for this is because the sedimentation of red cells is slower when you have more red cells. The red cells basically repel one another and cause the sedimentation to go more slowly. So when you have less red cells in the setting of anemia, there's less red cells impairing one another's sedimentation rate down to the bottom of the tube, and therefore the ESR goes up. And then finally, renal disease is known as a cause of an increase in SED rate. Some of this is because many patients with renal disease have anemia from low EPO levels, but there are other reasons. There are a couple of situations that can lead to a very low ESR. Remember, normal is less than 30, but very low, like less than 5, is unusual. This can happen if there's a low level of fibrinogen in the serum. Remember, fibrinogen is one of the things that generates the SED rate and causes red cells to stick together and to sediment down to the bottom of the tube. Heart failure is also often listed as a cause of a low ESR, although this is controversial. It's not clear this definitely happens, and the mechanism of a reduced ESR in heart failure is unclear. Second cause of a very low ESR is anything that causes the red cells to have abnormal shapes. So you can see this in sickle cell anemia, spherocytosis, and microcytosis. Polycythemia can cause a very low ESR. This is the opposite mechanism that we discussed on the last slide for anemia. And the important thing to know clinically about all the things listed on this slide is that they can lower the ESR even though there may be inflammation going on. So a person who has an inflammatory process but has sickle cell anemia may not have the normally increased ESR that you would see, and that's because there is something going on to raise the ESR, that's inflammation, but something going on to lower the ESR, that's an abnormal red cell shape. And then finally, there are a couple of substances known as negative acute phase reactants. The level of these substances fall in the setting of inflammation. Their synthesis is inhibited by cytokines. The most famous one is albumin. You will see this in the hospital and the ICU all the time. Patients with a chronic inflammatory process will have low albumin levels. Two others worth knowing are transferrin, which is involved in iron metabolism, and transthyretin, which is one of the substances that contributes to senile amyloidosis. And that concludes our video on inflammation principles.